Hello and welcome to this VetLit podcast. VetLit Minis are journal club podcasts on a range of topics, small animal focused, so you can keep up to date even if you just have a few minutes spare. Today we're going to be learning about direct oral anticoagulants, which we might call DOACs, specifically Rivaroxaban and apixaban. This and a follow-up podcast of burning questions on thromboprophylaxis are going to be amazing learning opportunities because we're joined by two real experts in the field. We have Dr. Alex Lynch, Associate Professor in Emergency and Critical Care at North Carolina State University College of Veterinary Medicine, and Dr. Rob Goggs, Associate Professor in Emergency and Critical Care at Cornell University College of Veterinary Medicine. Now, firstly, thank you so much for joining us, essentially, and for the schooling I'm about to receive.
Not at all.
Thanks, Simon. Yeah, pleasure.
And in particular, the reason that Alex and Rob are here is that they're lead and final authors on a recent study entitled Comparison of the Pharmacokinetics and Pharmacodynamics of apixaban and rivaroxaban in Dogs, and that's published in JVIM. And a really brief sort of fly through to cover some terminology would just be to say that the term thromboprophylaxis covers both antiplatelet therapies and anticoagulant therapy, where antiplatelet therapy typically equates to aspirin and clopidogrel. Anticoagulants, conceptually anyway, act at various sites on the clotting cascade. Classically, we might think of heparin, enhances the action of antithrombin, warfarin, that impairs regeneration of vitamin K dependent clotting factors, but now direct oral anticoagulants, so DOACs, like rivaroxaban, that work at the level of factor 10A. Brackets, antiplatelet therapy is better justified in arterial thromboses and anticoagulants better justified in venous thromboses, including PTE. But maybe as an introductory question for you, Alex, very broadly, it seems as though we're maybe presented with more and more cases in which anticoagulation can be justified. You know, your dog with IMHA, and maybe we're using rivaroxaban in those dogs, but there wasn't loads of evidence on the use of those drugs before we started using them. So, was there a reason that rivaroxaban turned up on the scene first? And how does that sort of set the scene for your study? Why did you want to document this and compare these two drugs?
Yeah, that's a good question. I agree that Rivaroxaban did seem to be the drug that people were interested in. That's the one we were playing with on clinics, and then started to do some research, and seemed to be the drug that was coming out quickly. In comparison, though, with people, apixaban is from a release perspective, was released around the same time as Rivaroxaban, but seemed to be quite a popular choice in terms of the human medical field. And so we then, within 3 to 5 years or so, started to see apixaban publications coming out too.
Mhm.
And so part of the rationale for us looking at this really was to ask the question, is there a lot of difference between the two? They work similarly, but is there an advantage of one over the other? And to start chipping away at that question, this was some important information for us to get in healthy dogs.
Great. And so then I suppose that leads quite nicely into what did you aim to document, to compare? How did you actually go about the study? What was the setting?
And so we looked at sort of a mixed population of dogs in the sense of different sizes, different sexes, look to see what ongoing administration for sort of a week at a time looked like for these dogs. We've got some data what 1 or 2 days looked like, but what was the effect of giving it for a week in terms of the impact on their overall coagulation status? And then sort of another interest wasn't only just what effect did it have on anticoagulating them, but also once we stopped the drug, did it lead to rebound hypercoagulability, which has been something discussed in human medicine, but that we don't really have a good sort of grasp on in dogs, if that's something we should even be worried about.
Yeah, that rebound hypercoagulability concept is referred to a couple of times, isn't it? But with a bit of indecision, we
Yeah.
don't really know whether to consider it, right? And maybe we can get a bit more data on that. So, what if I asked you to pick out any specific um, any specific readouts of, you know, bioactivity of these drugs over time that were of particular relevance to you? And then I'm going to ask you later to distill it down to your major personal take homes or your major things that you found most interesting. Where would you start?
Can I jump in, Alex? I've, I've been quiet this long and
Yeah,
I can
sure.
barely contain myself.
Yeah.
So this is one of the tricky things I think with the darks because if you look in the study, there are three different kind of measures. We've got measurements of the actual concentration of the drug in plasma. We have a calibrated anti-10A assay, which correlates very closely with the drug concentrations as you would hope for. And then we have a different biologic readout. And because one of the kind of questions really was, okay, if you give the same dose at the same frequency to the same exact set of dogs, do you get equivalent biological activity? Do they get absorbed in the same way? Do they get metabolized and excreted in the same way? And do you ultimately end up maybe with different plasma concentrations, but the ultimate same biologic effect? And people use the anti-10A activity as a biologic readout, but strictly because it's a specific calibrated assay, it's really more of a readout of drug concentrations. It's not strictly concentrations, but it's calibrated on a concentration basis. But what we're really interested in is, okay, if I give this amount of this drug to this dog, will it have an effect to reduce the risk of thrombosis? Am I going to suppress the coagulation system, suppress the
Mhm.
hemostatic system such that I diminish the risk of thrombus formation? And for that, you probably need a different readout. And that's one of the tricky things because this is a healthy dog population. They don't have thrombosis. And so we can't use a kind of clinical endpoint like the thrombus disappeared. So what proxy can we use? And we opted for thrombin generation as a perhaps the best in vitro assay to say when you give this drug, it actually has a biologic effect that should translate into a thromboprophylaxis.
Okay, yeah. So then, because yeah, we often read about, gold standards of using anti-10A assays, but that's nice to know that it's perhaps a closer gauge of drug concentration than biological effects. That's quite a nice summary. And I suppose what you're describing there, right, is actually well, literally the study title, isn't it? It's pharmacokinetics plus pharmacodynamics, isn't it? It's what drug concentrations are doing versus actual the clinical effect, and your chosen output for clinical effect in these dogs was thrombin generation. So then, what would you say? Because I've got them all in front of me here, but it would take us an age to go through them. I've got a few take homes. Can I put them to you and decide, and you decide if they were appropriate take homes or not?
Sounds good.
Or do you have any that were top of your list? What if I said to you, what was the most important take home for this from this gauging of the behavior of these two drugs inside dogs over the course of 7 days and how that translates to clinical relevance? What would you say?
You go first, Alex.
Yeah. Thrombin generation was inhibited with both drugs. And to me, that then sort of jumping several steps ahead makes me okay to consider either drug until proven otherwise to be likely to perform similarly. So I don't think I've got based on this data set at least, one isn't charging ahead in terms of being superior to the other. And I know we've not looked at all the things you need to sort of prove superiority, but that I think is one good initial step to say these drugs both did what we intended them to do.
And do you
Yeah, I
have
think that's probably take home number one, right? Because we wanted a true kind of head-to-head comparison in the same population of dogs. I think the other take home that was perhaps a little surprising and I don't know, concerning might be too strong of a word, but I was surprised by how much inter dog variability there was. And there was also intra-dog variability. So if you look at the kind of breakouts of some of the graphs where we have the drug concentrations and the resulting anti-10A activities broken out by individual dog, you can see there's quite a lot of dog-to-dog variation,
yeah,
but for the same dog, there is some variation between different days.
right.
And That's surprising because one of the aims of these types of medications is to have more consistent PK so that you perhaps don't have to monitor the resulting biologic effect on as frequent a basis, right? That was one of the major things they were looking for as a move away from warfarin, where monitoring was essential, to a situation where you could give a dose and expect a biologic effect without the need to monitor. And so I was surprised by how much variability there was.
Okay, great, thank you. Okay, and I suppose my Simon's take homes, in case I might put them to you and decide if they were appropriate or not, and feel free to put me in my place. But actually, to me, it was useful to know that biological effect gauged by perhaps more appropriately the thrombin generation itself, but also you've been quantifying the anti-10A activity as well. It begins very soon, within a day for both drugs. That's pretty valuable information to know, even if we might have had a glimpse at that before. That peak activity, at least on anti-10A, it was peaking or plateauing after about three to 5 days, perhaps a little bit earlier in apixaban. And then one other thing that I suppose I thought perhaps of relevance anyway for people that have these available. But if you wanted to gauge bioactivity in practice, people often asking, can I be measuring PTA, PTT, things like that? But I didn't. It's not going to tell you much based on your gauging of PT and APTT in these dogs. And then the other really cool thing I thought was that you tracked that biological effect as we're calling it. It's gone within 24 hours of discontinuation, and that might well have some implications, right? For we mentioned the curative guidelines and discontinuation of antithrombotics in patients with, for example, IMHA or just dogs on DOACs in general, because those animals with what we call a low to moderate risk of thrombosis, you might choose to withdraw them pre-surgery or pre-invasive procedure. So knowing that the activity is gone within 24 hours, that's pretty helpful. So those to me were what I wanted to be able to conclude. Are they fair? Are those fair conclusions?
Yeah, I'm gonna jump in on the clotting times thing because I think that's actually a really crucial differentiator here.
Yeah.
And the having both the thrombin generation and the clotting times in the same time points, the same dogs, is really helpful for me because you can see that if you look at the supplementary materials where we overlaid the thrombin generation parameters for the two drugs, over the top of each other, you can see that they're basically the same. But the effect on the prothrombin time in particular was definitely different between the two drugs. And so we know that thrombin generation is, heavily suppressed, and as you indicated, that happens quite quickly, and it basically plateaus, on a constant dosage of the drug. But the equivalent prolongation of the PT is more pronounced with Rivaroxaban than it is with apixaban.
Okay.
And I think that doesn't indicate a difference in biologic effect. It simply indicates a differential sensitivity of the assay. We used exactly the same assay configuration for the two sets of prothrombin times. The prothrombin time is more prolonged in this assay configuration by Rivaroxaban than it is by apixaban, but without any differential in terms of their biologic effect. So by all means, you can certainly measure the two things, but for me, the prolongation of clotting time is perhaps more of a indicator of concern, like, okay, the prothrombin time doubled, maybe I'm giving too much of the drug, rather than it being a target to say, I need to prolong the prothrombin time. Particularly for apixaban users, it may actually be harder to prolong the PT depending on how the assay is set up, and it shouldn't be a target to chase after.
Okay. Yeah, great. Thank
And
you.
Rob, from your experience, there's such variation in the reagents, right, for the PT/PTT that I think that's something that I think we should bear in mind too. Like if we're extrapolating this to the coagulation machine that we've got in our ICU, that's not the same assay that Rob's done on the benchtop at Cornell.
Yeah.
So they aren't apples for apples either.
No, absolutely. Whether we're talking about whole blood versus plasma, the concentration of the activator, the incubation time, and how we're detecting the endpoint will all have pronounced effects on the sensitivity of the assay to the drug. And so comparing my assay, even if mine's plasma and Alex's plasma,
Yeah.
they may be configured or run differently or detected differently, and they won't be interchangeable. And certainly if you're doing patient-side whole blood, that's a whole different story. So if you're going to use these devices in any kind of way for monitoring, it needs to be done consistently, that you use exactly the same monitor, done in the same way, and that you bear in mind that some of these things have the potential for interference, right? That changes in hematocrit, changes in fibrinogen concentration might actually impact your assay. So it's simple but not straightforward, or straightforward but not simple.
Yeah. Okay. And then so my sort of final question is going to be on that, we didn't find any evidence of rebound hypercoagulability, which is also pretty reassuring, right? So then would you want more evidence before being able to recommend that discontinuation can be abrupt or should be abrupt in more clinically, well, in actual clinically affected dogs? Or yeah, do you need more information, or are you happy to start reaching for that conclusion yet?
It's a piece of the puzzle, but normal dogs are not dogs with
Yeah,
IMHA or glomerulonephritis, So I think when the stakes are high, like a dog with IMHA, particularly early on in their disease course, I don't think this evidence is enough to strongly say, hey, yeah, just discontinue the Rivaroxaban, that dog will be fine.
yeah,
But it is a piece of the puzzle, So
yeah.
maybe if we can look at it in sick dogs, those dogs that are on our radar at being at risk, maybe we'll find the same. But uh, we don't know enough yet, I think.
Yeah.
Yeah, I would agree. I think there's definitely a chance still that patients who are abnormal may have a different configuration of their rebound than the healthy dogs.
Yeah.
I think what says for me is if you're in a situation where you have to abruptly discontinue, the risk may be low. It's probably not zero, or at least not quantifiable at this point. But there's not already a signal that that's going to be a problem. In healthy dogs, it doesn't appear to cause a rebound. And so if you had a situation clinically, you needed to abruptly discontinue because of a procedure that you weren't anticipating having to perform, then the risk may be relatively low.
I guess sort of related to that, the other thing I would say is, we said they sort of return to normal within 24 hours. Is thinking about how these drugs are excreted too. So if you've got a dog that has kidney insufficiency, their PK/PD could look different. So
Yeah.
if you've got a dog that needs a feeding tube placed because of its kidney disease, 24 hours may be okay, but perhaps discontinuing for a bit longer would actually be safer.
Perfect. Okay. Well, thank you very much. And actually, that's it for today anyway. And I first of all, I just like to say thank you so much for joining us.
Yeah,
Um,
you're very
My pleasure.
welcome. Thanks a lot.
it's a real pleasure. The aim of VetLit is to make veterinary literature both more accessible and more accessed, and hopefully we've secured that in some small way today. Remember, you'll almost definitely find an article to read that interests you on the vetlit.org site. You can check back there, here, or via the email updates for more, and otherwise have a great day. It's goodbye from Rob and Alex, and it's bye from me. Bye for now.